Professor Thiravat. The last section of the first section is introduce Professor Uayporn Kawatanasbat. So Uayporn is right now the assistant professor in the gastroenterology division, Department of Internal Medicine. She also one of the experts in the ES field in Thailand. She will talk ESD in the lower part of the GI tag. Please welcome Professor Uayporn.
Ohayo gozaimasu. Thank you, Professor Nantari, for your kind introduction. I think Yamamura Sensei also mentioned about my experience in Japan. So today it's like a wrap up after I have graduated from his training for about 5 years, and this is also the the summarize of the how colorectal ESD has been performed in Siriraj Hospital. So I think we have both GI endoscopists and the surgeon that perform ESD. I think Professor Somchai, Professor Asada also have started ESD in the colorectum for almost 10 years ago. And after that, Professor Chainarong and also Professor Varayu have been doing this. And as Yamamura Sensei also mentioned that he visited Thailand for many times. And as I remember in my memory that I has a first experience with him doing the full ESD step in the cecum in this case as about 2018. And at that time, we cannot find a big lesion for him. So he just doing it in like 15 or 20 minutes to finish this kind of lesion. And after that, we gain more experience about ESD, and we have more endoscopists to performing ESD. And this is my first case after I have graduated from Yamamura Sensei. This is the rectal lesion, so about 5 centimeters. And I'm so proud that this is my first case without any complication. At my first start, I have to call a surgeon like Professor Chainarong. So please back up for me if I have any complication or I cannot finish the case in time. So please stand by for me. I'll let you know about the protocol of the colorectal polyps management in Siriraj Hospital. We follow the ESGE and ASG guideline that we select the case without the deep submucosal invasion and larger than 20 millimeter to be decided between EMR and ESD. And we also try to follow the Japanese guideline also to identify the pit pattern, the vascular pattern, and also the morphology of the LST lesion. Which lesion should be resected en bloc. We will send the patient and schedule for the ESD. Our protocol started from the pre-ESD evaluation. We try to use the image-enhanced endoscopy and also the magnifying endoscopy if available. Use the morphology to identify any risk of deep submucosal invasion. Some doctor might take biopsy at the lesion if they're suspicious of the invasive carcinoma. But we are trying to tell them that if you are not aware of any deep invasion, you just don't need to take biopsy before the dissection. And some patients may need to evaluate for the lymph node metastasis before, so CT scan may be needed in some cases. During the ESD procedure, of course, we are trying to perform the en bloc resection with the conventional ESD, or sometimes to save the time, we perform the hybrid ESD. And when the en bloc resection was failed, like any complication occur during the procedure or it takes too much time, we change our plan to doing with the piecemeal EMR. But we usually do some APC around the mucosal defect according to the recommendation, and also many papers have suggested that APC might reduce the risk of polyp recurrence after the piecemeal resection. For post-ESD procedure, we also follow the protocol of the poor or unfavorable factors. If the pathologist evaluation have any sign of poor factors, we will send the patient for the surgical resection. So until now, almost 10 years ago, we have collected the case. I have to thank Dr. Anuma and Dr. Suchana for the retrospective and prospectively collected the data. Almost 150 cases have been doing until this year, and the patient characteristic was quite similar to any collected data about the ESD patient. As you can see in this slide, the most common morphology are flat lesion, and the size can be ranged from 13 to 10 centimeter. The most common pathology are adenoma. Let's see our outcome. We accomplished the ESD lesion about 93%. We have curative resection about 87%. And as Yamamura Sensei have shown in his slide that the curative resection in from Japanese side is about over 90%. So we are approaching that. The en bloc resection is not quite good, about 62%. As I mentioned to you earlier that if some cases are unable to do it en bloc, we change our plan to do it like piecemeal. For the complication, most common complication are perforations, but most of them we can manage with the conservative strategy like for the crypts, and only 2.7% need to go for the emergency surgery. We have more and more cases nowadays. Each year we have like 30 cases per year, and I think it's been increasing. And also we collect the resection speed, and the 9 centimeters square per hour is like a standard speed for the colonic ESD. And we are trying to overcome this speed. Let me show you some example case. This is a 5 centimeter lesion with a 0 to A involved in the dentate line. And this case, we use the speedboat device to resect the lesion in en bloc. And this lesion was present in the WEO meeting. Another one is about 8 by 7 centimeter flat lesion, also in the lower rectum. A lot of severe fibrosis and non-lifting area was observed, and the pathology turned out to be tubular adenoma. And I also made some complication like perforation in this case, but eventually the patient was well, and I can manage her conservatively. There are also some nightmare for like this patient, assessed size 1, a big one, 6 centimeter in the rectum also. And I also made the through layer cutting, the perforation. And it was completely closed by the hemoclips, and the patient don't need any surgical treatment. This is also a difficult one, a 5 centimeter lesion in the cecum. I don't know why, but during the dissection, you can see I have made a big hole here, but the patient didn't get any pneumoperitoneum. And after we try to accomplish the removal of the polyp, and we can see a big hole here, but the air is not going through the intraperitoneal part, so we suspicious of any adhesion between the cecum and the peritoneum. And this case was finally closed by over the scope clips. The last case was an unaccomplished case. This is because of our preoperative diagnosis was not good enough. You can see the depressed area in the central, and at first we think that is also genetic to be that we can consider for the endoscopic resection, but after we trying to do some dissection, it was unable to get into the submucosal space, and finally patient was sent for the surgery, and the pathological result turned out to be the adenocarcinoma. So in my experience, I think to get a high quality ESD, so to catch up with the Japanese standard, the first most important thing is to select an appropriate lesion for the ESD. So the high quality screening colonoscopy, also the AI is required. And also I emphasize many younger doctors to have a good photo documentation. We have to practice more on the polyp characterization using the image-enhanced endoscopy and the magnifying endoscopy. About the strategy for the ESD, I think we have to practice more on the traction techniques, also any traction device, and we have to aware of the serious complication. So last but not least, I think our ESD cannot be successful without a big support or a great teamwork also from surgeon, from the anesthesiologist, from the pathologist, and the most important from our nurse. So I'd like to thank a big support from Professor Goto and his team, and Yamamura Sensei and Hara Sensei, Miyahara Sensei for your kind supporting me for gain a lot of experience during staying in Nagoya. So thank you very much.
Thank you, Minister Professor Uayporn, for I think it's a big number, more than 100 cases of ESD low part. The first section already finished. I open for the Q&A.